Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. First, just like to start off and say thank you. I've gotten so many wonderful reviews, so many wonderful notes, emails, just thanking me for the podcast. And, I can't tell you how much that means to me. It's incredibly humbling to know that I've been able to literally reach millions of people on this podcast. And, I just wanted to say thank you guys for sharing, for comments, for, everything you guys have done for me and this podcast. And I fully intend to keep rolling with it because I really, really appreciate everything that it's brought me personally from a selfish standpoint, as well as just being able to help a ton of people. It's really, really cool. And I never would have envisioned this when I first started this podcast. So sorry about the off-topic note today, but just feeling really, really thankful for everything that you guys have done to help share this podcast, grow the audience, and increase the numbers of people that listen to it. It's been really, really special. So thank you. With that note, you can definitely continue to support this podcast by going to meded101.com/store. We've got BCPS, ambulatory care, geriatric, NAPLEX study materials, all sorts of different stuff there. Also got stuff for pharmacy technicians, nurses, PAs, physicians, all that good stuff. So go check that out. Support the sponsor at meded101.com/store. All right. Drug of the day today is, I've got 5 drugs of the day today. We're continuing on with our top 200 list. We're on 111 through 115. First one I want to cover is Clindamycin. Brand name is Clindamycin. It's technically classified as an antibiotic. Mechanistically, it inhibits bacterial protein synthesis, and it does this by binding to the 50S ribosomal subunit. Indications, it's got a bunch that it can potentially be used for, and that's differentiated probably by topical versus systemic because it comes in both formulations. So from a systemic standpoint, osteomyelitis, skin and soft tissue infections. Topically, we've got acne, rosacea potentially. Again, tons of different indications for this medication. Probably the biggest concern, the biggest issue, or two of the biggest concerns why you don't see this medication used a ton. It can cause some significant GI adverse effects, and particularly has a boxed warning for an increased risk of C. diff diarrhea. So that's an important one to remember. Definitely something that could come up on your pharmacology or board exam. Probably the other big downside from a practical standpoint is it's got to be dosed pretty frequently because of a short half-life. So you see this medication often dosed 3-4 times a day, which, for patient adherence can be a challenge for sure. So again, I mentioned some of those formulations. We've got, topical gel, vaginal cream, injection. We've got oral, plenty of different formulations, which is great. We always want that for part of the drug properties. Other kind of adverse effects that I wanted to mention besides GI and that boxed warning for C. diff, there has been reports of elevated liver enzymes, and with most antibiotics, you can also have skin reactions, that type of thing as well. Administration, one important point I wanted to make here. So if we're taking the oral formulation, oral capsules, it's recommended to take with usually a full glass of water. The capsule and the medication itself can cause some esophageal irritation. So it's important that we kind of flush that medication down, make sure we get it down and it doesn't stick and irritate that esophagus area. Finishing up with this medication, drug interactions. Biggest thing I would say no here is CYP3A4. CYP3A4 inhibitors will increase concentration, while inducers will decrease concentration. And this medication I have covered previously in much more depth, so if you want to go catch that episode, go to the reallifepharmacology.com website, search Clindamycin, and you should see it, no problem. Moving on, we got drug number 112. We've got acetaminophen. Brand name is Tylenol. Very commonly used, of course. It is classified as an antipyretic, an analgesic. Important differentiator between acetaminophen and NSAIDs. NSAIDs, we get that anti-inflammatory action, whereas acetaminophen, we don't. So, something like rheumatoid arthritis flare, for example, and NSAID is going to be much more helpful in that because it's got that anti-inflammatory component. Or gout flare, another situation where you've got lots of inflammation. NSAIDs will help get that down. Acetaminophen does not. So that's probably one of the biggest differentiators there. Mechanistically, it's really not that well understood. They believe it's got some CNS action, maybe in relating to some of the COX isoforms, but again, not something, honestly, I've ever been asked on a pharmacology or board exam is the mechanism of acetaminophen, and that's because I think it's a little bit, not well understood exactly how it works. Side effect profile, liver is probably the biggest thing you got to worry about, and that is typically going to be with higher than usual doses. You start getting above 3,000 milligrams, 4,000 milligrams per day. That increase for liver toxicity goes up, certainly. Otherwise, other adverse effects, we've got skin reactions. They have been reported. Again, tons of people use acetaminophen, so again, not incredibly common. You maybe see some stomach upset. I've probably seen a little bit more diarrhea with the liquid formulation, particularly if patients have to use larger amounts of liquid. Let's say you've got, an adult or an older child that needs, a little bit more of the liquid to get the dose that we want to get. Maybe a little bit higher incidence of diarrhea. I've at least seen and heard that happening. There is IV formulations, oral formulations, obviously liquid formulations. With patients, really, really important to educate about all the different products that have acetaminophen in them. And patients need to ask when they start taking over-the-counter cough and cold or anything that has analgesic properties over-the-counter. There's a very good chance that it's got some acetaminophen in it. So really, really got to pay attention to that. And then obviously if somebody's using, a combo prescription product like, acetaminophen and hydrocodone, for example, again, another situation there where we want to make sure that we're, tabulating the amount of acetaminophen being taken and ensuring that we go through over-the-counter use and medications with patients to make sure they aren't doubling or tripling up, for example. Liquid dosage forms, particularly, parents, caregivers of kids, be sure they are comfortable with dosing acetaminophen liquid. Okay, they've got to be able to do the measurements. Typical pediatric dosing, I've seen this come up definitely on exams, 10 to 15 milligrams per kilogram per dose. Every 4 to 6 hours is the usual range, recommended range for acetaminophen in pediatrics. Drug-drug interactions, hepatotoxicity, alcohol, and then I think of other medications as well that can do this, methotrexate, amiodarone, rifampin. Those can all potentially have that additive effect and contribute or increase the risk for hepatotoxicity. Some of the enzyme inducers may decrease the effectiveness, decrease concentrations, carbamazepine, phenytoin, for example. Rarely, I have seen some alterations in INR with warfarin. Usually, that's at the higher dosages of acetaminophen, which we sometimes do in geriatric patients. So let's say you go from 0 to 2,000 or 3,000 milligrams a day of acetaminophen. That's probably a lot more likely to throw off an INR than a patient taking 500 milligrams once a week, for example. So take that one with a little bit of grain of salt. But yeah, if you see abrupt changes, big increases in acetaminophen, you may want to double check and get that INR and make sure we're not causing those INRs to be elevated and increasing the bleed risk there. Moving on, number 113, we've got ferrous sulfate. Brand name is Fiasol. It is an iron supplement by the Ferrous name. You should have been able to pick that out, hopefully. We're basically replacing iron stores in the body. That's mechanistically what we're doing there. So it's used for iron deficiency. It can be used for anemia. That's obviously one of the major complications with iron deficiency. Restless leg syndrome, you may see ferritin levels assessed there as well. Those are the measures of iron stores, that ferritin level. But with low iron stores, restless leg syndrome is more likely. So that's definitely one of the things that clinicians check out when you get a patient reporting restless leg syndrome. As far as the dosage form, the oral formulation, 65 milligrams is the amount of elemental iron you're going to get from a 325 milligram tablet. So ferrous sulfate specifically is approximately 20% elemental. So 20% of 325, again, approximately 65 milligrams of elemental iron. Adverse effect profile. Darkening of stools. This can be really problematic. I've definitely had patients report that or call in that, they're noticing a change in their stools. Iron can definitely cause those darker stools. Usually not clinically a big concern or a big issue, but patients will typically be pretty concerned about that. Abdominal pain, some cramping sometimes can happen. Constipation certainly is reported with the use of iron as well. Be really, really careful. Pediatric patients, they get into things, they do stuff. Sometimes some of these iron tablets look like candy. We've definitely had plenty of reports of overdose situations where kids have incidentally ingested, numerous iron tablets, and certainly we can get iron poisoning or toxicity. So definitely important to educate the, patients about that, it's not just some, Joe Blow over the counter, not a big deal issue, to have it laying around, sitting around. Kids can definitely get into them, and we can have some significant consequences from that. From a polypharmacy standpoint, iron is one of those medications that, I often or sometimes request to get rid of. So I think it's always good to take a peek, at iron supplementation maybe every 6 months, and, reassess if that supplementation is still needed, because we have, plenty of potential complications, plenty of potential drug interactions that can happen on account of iron. Speaking of those drug interactions, with iron, most of the interactions are going to be because of concurrent administration. So giving iron with another medication can block the absorption of the other medication. So some examples here, tetracycline antibiotics, like doxycycline, for example, oral quinolones, levofloxacin, cefdinir, fairly commonly used, cephalosporin, levothyroxine, bisphosphonates. So again, some really fairly common medications can have their absorption blocked by absorption. So usually we get around this by separating. So we'll take, let's say they're on levofloxacin, so we'll take the iron in the morning and levofloxacin, in the afternoon or evening, for example. Another way to get around it, so if you've got a really, really short-term course of an antibiotic, let's say maybe it's 3 or 4 times a day or something, and, we're not sure exactly what to do with the iron. If it's a short-term, 3-5 days or something, if the patient's not in significant trouble with their anemia, you could at least discuss the possibility with the patient of maybe holding that iron just while they're on the antibiotic, to make sure we get all that absorption. Not something I've done routinely, but if you've got a patient that's really worried about it or something, or a very severe infection that you want to make sure everything gets treated appropriately, that could be a potential consideration there. One last drug interaction I want to mention is antacids and PPIs, H2 blockers. These can increase pH, which iron requires an acidic environment to have its absorption maximized. So naturally, giving a PPI, H2 blocker, it's going to reduce the acidity of the gut and the absorption potentially. So again, it can block the absorption of iron when we're using PPIs and H2 blockers and then acids in combination. With that acidic point, I did want to mention that sometimes you'll see iron given with vitamin C. That's something that's believed to obviously help increase the acidity of the stomach, so that co-administration, and improve the absorption of iron. So where I've seen this happen most often is you start a patient on iron, let's say once a day, for example, and we're not seeing any rise in ferritin and iron stores. Then sometimes I'll see clinicians, providers try to give it with vitamin C. They'll add on vitamin C with it to see if that helps promote and enhance absorption. All right, next medication is 114. It's Eletriptan. Brand name is Relpax. This is an anti-migraine agent. It acts as a selective agonist on 5-HT1B, 5-HT1D. Those are serotonin receptors on intracranial blood vessels and sensory nerves. This ultimately causes vasoconstriction and also potentially reduces some central nervous system like inflammation, which is purported to be the cause and contributing to that migraine headache pain. Indication, obviously acute migraines. Generally, we reserve the triptans, which this medication falls in that category, certainly. We reserve those generally for moderate to severe migraines. Adverse effect profile can cause some GI upset, some CNS changes like sedation and dizziness, for example. One thing I have discussed, I think, previously, and I'm not going to go into it in great detail here, but we do have some contraindications in relation to ischemic heart disease, and particularly uncontrolled heart disease. So that's an important thing to remember. If you've got a patient at high cardiovascular risk, we definitely need to take some time and kind of reevaluate, reassess the risk versus benefit of using a triptan like Eletriptan here compared to potential alternatives or other agents. So definitely something to pay attention to. If you know your patient's got a significant cardiac history, take the time, look at it, make sure a triptan is still okay, and that risk versus benefit has been discussed compared to maybe potential other options that we have in managing headaches there. One other important education point, I see patients use migraine treatment medications frequently sometimes. So let's do our best, try to remind patients, hey, this is not meant for prophylaxis, which I have seen done by patients before. It's only meant to relieve an acute migraine. We've got other medications that we can utilize for migraine prophylaxis if need be, if they have frequent migraines. But remember, triptans are meant for acute relief. They're not meant for taking continuously prophylactically. Drug-drug interactions. So CYP3A4 inhibitors can raise concentrations, so that's definitely one to recognize there, and it's generally recommended to avoid Eletriptan within 72 hours of a strong CYP3A4 inhibitor. A few examples, clarithromycin, ritonavir, itraconazole, ketoconazole. So again, very, very important to recognize that. Also contraindicated with MAOIs. I can't say I see MAOIs used very often, but that is important to note. Also, if you remember back to the mechanism of action, it's got some serotonin agonist action. So there is serotonin syndrome risk with this medication. If I've got a patient on, just sertraline 25 milligrams a day, I don't have really a high red flag for serotonin syndrome risk, but obviously as you escalate doses on the triptan and or escalate doses on SSRIs or SNRIs, or they're on numerous medications with serotonin activity. Let's say you got sertraline 200 milligrams a day, with high dose tramadol. Now we're talking about much, much higher serotonergic action in relation to all the agents that the patients are on. So again, is that, definitely theoretical risk for serotonin syndrome? And that risk certainly escalates as we talk about higher dosages and being on multiple medications that can have serotonergic activity. All right, last but not least, we've got drug number 115, and that is Methocarbamol. Brand name is Robaxin. This is a skeletal muscle relaxant. It basically blunts the central nervous system, is how this medication works, which ultimately helps with that muscle relaxation. Indication, muscle spasms, pretty much the only thing I ever see it used for. Adverse effects, this is an older type agent with lots of CNS depressant type action and some anticholinergic type action as well. Dizziness, drowsiness, confusion, fall risk. And as you can imagine, with all those potential adverse effects, including some anticholinergic action potentially, dry eyes, dry mouth, urinary retention, constipation, this is not a friendly medication in the geriatric patient population, and it shows up on the Beers criteria. Some other things to think about, alcohol. Very, very important, I would say, to probably avoid alcohol with this medication. We've certainly got additive CNS depressant type action. Obviously, adding alcohol on top of this medication, paying attention to the risk for, driving, motor vehicle stuff, operating heavy machinery. Those are all potential issues and concerns with patients with using Robaxin. And then, that alcohol component can just, double, triple, the effects of this medication. So important to pay attention to that. Half-life is really short, so we need to redose this medication usually multiple times per day. So it's got 3 to 4 times daily dosing. Again, that may vary depending upon if you've got a patient where it's like, my muscle spasms only seem to bother me at night. Well, then it's like, okay, maybe we only need to take it at night, which is something I've certainly seen done in practice there. Other drug-drug interactions I did want to cover a little bit. So that CNS depressant action is going to be the most important thing that I would want you to remember. I alluded to the issues with alcohol, certainly, which has that CNS depressant activity. Other medications, think of anything used basically for sleep, sedative type purposes, potentially that has CNS depressant activity. We're talking opioids, benzodiazepines, first generation antihistamines, so doxylamine, diphenhydramine, for example. Z-drugs for insomnia, for example. These all have sedative-type properties and can certainly add on to methocarbamol's effects. All right, well, I think that's going to wrap up the podcast for today. Do me a huge favor, support the sponsor, meded101.com/store. All purchases there go directly to support this podcast. We've got lots of materials that'll help you pass board exams like BCPS, ambulatory care, BCMTMS, geriatrics exam, NAPLEX, so go check those out at meded101.com/store. I've also got books that can, help you learn medication management and obviously highlight some of the most important things that I see in practice that will help you take better care of your patients. So again, go check all those links out, meded101.com/store. If you'd be so kind, leave a rating, review on iTunes, wherever you're listening. Share us with friends, colleagues, students. I greatly appreciate that. It's helped me grow this podcast beyond my wildest expectations. So thank you for that. And if you got comments, suggestions, questions, mededucation101@gmail.com. I do my best to try to reply to every email that I get. So don't hesitate to touch base with me there. If you want to connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. I certainly try to respond to comments, messages there as well. With that, I'm going to sign off. Thank you so much. Take care and have a great rest of your day.